about Assalamu alaikum. This is the second lecture about pancreatic disease. We talk pancreatic, anatomy, physiology, and injuries, and starting acute pancreatitis, causes and the clinical feature. Now, investigations of pancreatic disease regarding acute pancreatitis. Investigation includes serum amylase level 3 times above the normal. Serum amylase also elevated in abdominal trauma, in hepatitis, elevated in cholangitis, and acute cholecystitis, even in perforated viscous. But in pancreatitis, serum amylase level 3 times above the normal. Serum levels of lipase also elevated. Contrast enhanced CT scan. That's to say, injection of IV contrast or oral contrast and take CT scan. MRCP also included as investigation, non-invasive in acute pancreatitis. And assessment of the severity of pancreatitis. Severity of the pancreatitis assessment should be performed in patient at 24 hours, 48 hours, and 7 days after admission. The Ranson and the Glasgow scoring systems are specific for acute pancreatitis and are score of 3 or more at 48 hours indicates severe attack. إذن عندنا مهمات specific للبنكرياتيتس للأكيوت بنكرياتيتس هم رانسن score and Glasgow score. Ranson criteria and Glasgow score مهمات. Regardless of the system used, persistent organ failure indicates a severe attack. A serum C-reactive protein levels more than 150 milligram per liter at 48 hours after the onset of symptoms is also an indicator of severity of acute pancreatitis. There is mild, moderate, and severe attack of pancreatitis and mild acute pancreatitis. In mild acute pancreatitis, there is no organ failure, no local or systemic complications, while in moderately severe acute pancreatitis, there is organ failure that resolve within 48 hours. Transient organ failure resolve within 48 hours, 2 days, and or local or systemic complication without persistent organ failure. Organ failure is specific for acute attacks, severe attacks. In severe acute pancreatitis, persistent organ failure more than 48 hours. Single organ failure, multiple organ failure, and this is assessment of severity of acute pancreatitis. This table includes Ranson criteria, Ranson score, and the Glasgow score to predict the severity of acute pancreatitis in both systemic diseases is classified as severe when 3 or more factors are present. This is on the left, Ranson score. On admission, the age more 55 years, white blood cell count more than 16, and blood glucose more than 1.1 millimole per liter, and lactic dehydrogenase more than 350 units per liter, and AST more than 250 units per liter. This is on admission, while after 48 hours, يعني after 2 days, hematocrit full of 10% or greater, and the blood urea nitrogen rise more than 5 milligram per deciliter, arterial oxygen saturation less than 8 kPa, and serum calcium less than 2 millimole per liter, that's to say hypocalcemia, and base deficit more than 4 millimeter per liter, and the fluid sequestration more than 6 liters. This is important on admission, criteria on admission, and the criteria within 48 hours. While Glasgow scoring, within 48 hours, the age is more than 55 years, white blood cells more than 15. بينما بالرانسن هو more than 16. بالجلاسكو more than 15. Blood glucose more than 10 millimole per liter, and lactic dehydrogenase more than 600 units per liter, and serum urea more than 16 millimole per liter, arterial oxygen saturation less than 8 kPa, يعني 60 millimeter mercury, and serum calcium less than 2 millimole per liter, and serum albumin less than 32 gram per liter, because sometimes there is hypoproteinemia. Early management of severe acute pancreatitis, admission to the high dependency unit or ICU. Pancreatitis is an important disease, should be treated well. That's to say, admission to high dependency unit or ICU, analgesia, aggressive fluid rehydration, supplemental oxygen, invasive monitoring of vital organs, central venous pressure, urine output, and blood glucose gases. All these should be checked, and the frequent monitoring of hematological and biochemical parameters, including liver and renal function, clotting, serum calcium, and blood glucose. Nasogastric drainage only initially, يعني نستخدم النيزوغاستريك tube, and antibiotics of cholangitis suspected. Prophylactic antibiotics can be considered. CT scan essential of organ failure, clinical deterioration, or signs of sepsis develops. ERCP within 72 hours for severe gallstone, pancreatitis, or signs of cholangitis, and supportive therapy for organ failure if it develops. Inotropes, ventilatory support, hemofiltration, and extra. If nutritional support is required, consider enteral nasogastric feeding. Complications of acute pancreatitis include system complication and local complication. And system complication more common in the first week, including cardiovascular complication like shock, arrhythmias, pulmonary, ARDS, يعني acute respiratory distress syndrome, renal failure, hematological, DIC, and metabolic complication, hypocalcemia, hyperglycemia, hyperlipidemia, gastrointestinal ileus, neurological complications of acute pancreatitis like visual disturbances, confusion, irritability, and encephalopathy, and miscellaneous complications, subcutaneous fat necrosis, and arthralgia. These systemic complications cannot systematic, cardiovascular, pulmonary, renal complication, hematological, metabolic, gastrointestinal, neurological, and subcutaneous fat necrosis and arthralgia. While local complication usually develops after the first week, local complication, acute fluid collection, sterile pancreatic necrosis, phakic pancreatic necrosis, pancreatic abscess, pseudocyst formation, and pancreatic ascites, pleural effusion, portal splenic vein thrombosis, and pseudoaneurysm. Pseudocyst formation, this is important because it is related as a complication of pancreatitis. It is a collection of amylase-rich fluid enclosed in a well-defined wall of fibrous or granulation tissue. Formation of pseudocyst requires 4 weeks or more from the onset of acute pancreatitis. It is usually identified on ultrasound or a CT scan. Endoluminal ultrasound and aspiration of the cyst fluid. The fluid should be sent for measurement of carcinoembryonic antigen levels, amylase levels, and cytology. يعني لازم نعرف إنه if there is malignant features together with pancreatitis or just an inflammatory process, and cytology is important. And the fluid from pseudocyst typically has low carcinoembryonic antigen level, and levels above 400 ng per ml are suggestive or mucinous neoplasm, and the mucinous neoplasms of the pancreas mostly malignant. Pseudocyst fluid usually has a high amylase level, but that is not diagnosed as a tumor that communicates with the duct system may yield similar findings. Cytology typically reveals inflammatory cells in pseudocyst fluid, and pseudocyst will resolve spontaneously in most instances. يعني نعطي وقت للpseudocyst because it is spontaneously resolved in most instances, but complication may develop. Pseudocysts that are thick-walled or large, over 6 centimeters in diameter, have lasted for a long time, over 12 weeks, يعني about 3 months, or have arisen in a context of chronic pancreatitis, are less likely to resolve spontaneously. And therapeutic interventions are advised only if pseudocyst causes symptoms, if complication develop, or if a distinction has been made between pseudocyst and tumor. Percutaneous drainage to the exterior and the radiological guidance should be avoided. Percutaneous drainage to the exterior and the radiological guidance should be avoided. It carries very high likelihood of recurrence, and it is not advisable unless one is absolutely certain that the cyst is not neoplastic and that has no communication with the pancreatic duct, or else a pancreatic or cutaneous fistula will develop. Endoscopic drainage usually involves puncture of the cyst through the stomach or duodenum. That's to say, at the time of endoscopy, there is endoscopic drainage through stomach or duodenal wall under endoluminal ultrasound guidance, and the placement of a tube drain with one end in the cyst cavity and the other end in the gastric lumen. Surgical drainage involves internally draining the cyst into the gastric or jejunal lumen. Sometimes we require surgical procedure that drain the pseudocyst to the stomach or to the jejunal lumen. Possible complications of a pancreatic pseudocyst: process, infection, and the outcome abscess and systemic sepsis. Rupture into the gut, causing gastrointestinal bleeding. Into the peritoneum, rupture into the peritoneum and causing peritonitis, and enlargement of the pseudocyst may cause pressure effect, causing obstructive jaundice from biliary complication or bowel obstruction due to the pressure of the pseudopancreatic cyst on the duodenum, and painful condition due to erosion into a vessel, hemorrhage into the cyst, and hemoperitoneum. Sterile and infected pancreatic necrosis and acute pancreatitis. refer to diffuse or focal area of non-viable parenchyma. Acute necrotic collection, acute necrotic collection. This is typically an intra or extrapancreatic collection containing fluid and necrotic material with no definable wall. And gradually over a period of 4 weeks, this may develop a well-defined inflammatory capsule and evolve into what is termed ward of necrosis. Collections associated with necrotizing pancreatitis are sterile to begin with, but often become subsequently infected, probably due to translocation of gut bacteria. Infected necrosis is associated with a mortality rate of up to 50%. It is high mortality rate. Infected necrosis, 50%. Sterile necrotic material should not be drained or interfered with, but if the patient shows signs of sepsis, then one should determine whether the collection is infected. Undiagnosed aspiration under CT scan guidance. The needle should never pass through hollow fissure. And a treatment, if the aspirated is purulent, if the aspirated fluid is purulent, the patient should be kept on antibiotic according to the severity and the drain inserted for drainage. The drain should be with large size when the aspirate is thick content. If sepsis persists, this needs pancreatic necrosectomy. If sepsis persists, this needs pancreatic necrosectomy. That's to say, exploratory laparotomy and debridement of necrotic pancreatic tissue. Patients with peripancreatic sepsis are ill for long period of time and may require management in intensive care unit, and the nutritional support is essential. The parenteral and nasogastric approaches are more popular on the assumption that they rest the pancreas. At the end of acute pancreatitis, we start in chronic pancreatitis. And chronic pancreatitis is progressive and inflammatory and destructive disease in which there is irreversible destruction of pancreatic tissue. It is a clinical course. Its clinical course is characterized by severe pain and in later stages, exocrine and endocrine pancreatic insufficiency because the pancreas is exocrine and endocrine gland. Etiology and pathology of chronic pancreatitis, mostly alcoholism in 60 to 70%. This is first important and commonest cause of chronic pancreatitis. Duct obstruction due to trauma or acute pancreatitis or pancreatic cancer, like periambulary tumor and even small stone impacted in the ampulla of Vactor. Congenital abnormalities is a cause of acute chronic pancreatitis and hereditary pancreatitis. Cystic fibrosis and hyperlipidemia, hypercalcemia, all these also cause chronic pancreatitis and autoimmune pancreatitis and idiopathic causes of pancreatitis, chronic pancreatitis. The onset of the disease, the pancreas, may appear normal. This is early. Late, the pancreas enlarges and become hard as a result of fibrosis. Fibrosis is one of the end results of chronic pancreatitis. The ducts become distorted and dilated with areas of both stricture formation and ectasia. يعني especially the common pancreatic duct or accessory pancreatic duct, area of dilatations and area of structure formation, and calcified stones form within the ducts. The duct may become occluded with a gelatinous proteinaceous fluid and debris, and inflammatory cyst may form. Histologically, the lesion affect the lobule producing ductular metaplasia and atrophy of the acini of the pancreas, and hyperplasia of the duct epithelium and interlobular fibrosis. Clinical features of chronic pancreatitis: pain is very important. Pain, the site of pain is dependent on the site of the disease. Head of the pancreas, the pain felt in the epigastric and right subcostal region, whereas if the disease limited to the body and the tail, the pain felt in the left subcostal region and radiation to the back. Nausea is common, vomiting may develop, loss of weight. The patient lifestyle is gradually destroyed by pain, analgesic dependent weight loss, and inability to work. Loss of exocrine function leads to steatorrhea in more than 30% of patients with chronic pancreatitis, and loss of endocrine function and development of diabetes and infection also. This can complicate chronic pancreatitis. And investigations: only in the early stages of the disease will there be a rise in the serum amylase. Tests of pancreatic function merely confirm the presence of pancreatic insufficiency, or that more than 70% of the gland has been destroyed. يعني pancreatic insufficiency requires at least 70% of the destruction of the gland. Pancreatic calcification may be seen on abdominal X-ray, CT scan, and MRI scan will show the outline of the gland and the main area of damage and the possibilities for surgical correction. In MRCP, will identify the presence of biliary obstruction and the state of pancreatic duct. ERCP is the most accurate way to elucidating the anatomy of the duct system and endoluminal ultrasound. Medical treatment of chronic pancreatitis, because there is medical and surgical treatment of chronic pancreatitis. First, we have to treat addiction, especially alcoholism, and stop alcohol consumption and tobacco, smoking, involve a dependency counselor or a psychologist, alleviate abdominal pain, because sometimes there is severe agonizing pain in chronic pancreatitis. It is attacks of severe pain. Eliminate obstructive factors, whether duodenal, bile duct, pancreatic duct, like periambulary tumor or stone. Escalate analgesia in a stepwise fashion. Refer to pain management specialist. For intractable pain, consider CT, endoluminal guided celiac axis block. Because of the severity of pain, sometimes we treat the severe attacks of pain by blocking the celiac axis, and sometimes splanectomy. Nutritional and pharmacological measures and diet, low in fat and high in protein and carbohydrate. Low in fat, high in protein and carbohydrate, and pancreatic enzyme supplementation with meals. Correct malabsorption of fat-soluble vitamins and vitamin B12. These also should be replaced. And micronutrient therapy with methionine, vitamin C, vitamin E, selenium may reduce pain and slow disease progression. Steroids sometimes indicated only in autoimmune pancreatitis for relief of symptoms, and medium-chain triglycerides in patients with severe fat malabsorption. They are directly absorbed by small intestine without the need for digestion. Reducing gastric secretion may help on the treatment of diabetes mellitus. Endoscopic and radiological or surgical interventions are indicated mainly to relieve obstruction of pancreatic duct, bile duct, or of the duodenum, or in dealing with the complication, for example, pseudocyst formation, abscess formation, fistula, pancreatic fistula, and ascites or variceal hemorrhage. In all these, you have intervention should be considered. And the prognosis of chronic pancreatitis is difficult to management. Chronic pancreatitis is a difficult condition to manage, and patients often suffer of gradual decline in their professional, social, and personal lives. The pain may abate after a surgical or percutaneous intervention, but tend to return over a period of time. Sometimes there is periodic attacks of pain in chronic pancreatitis. Proportion of patients, the inflammation may gradually burn out over a period of years, with this appearance of pain, leaving only the exocrine and endocrine insufficiencies. Development of pancreatic cancer is a risk in those who have had the disease for more than 20 years. Development of pancreatic cancer is a risk in those who have had disease more than 20 years, even who are pre-malignant condition, but for a long time. New symptoms are a change in the pattern of symptoms should be investigated, and malignancy should be excluded. At the end of chronic pancreatitis, I will start in carcinoma of the pancreas. And risk factor for the development of pancreatic cancer, demographic factors, age, peak incidence, 65 to 75 years. It is disease, carcinoma of the pancreas, disease of old age, and male gender, and Black ethnicity. Environmental and lifestyle, cigarette more susceptible than non-smokers for pancreatic cancer. Genetic factors and medical conditions, family history of pancreatic cancer, and germline, BRCA2, mutations in some rare high-risk families, and hereditary pancreatitis, 50 to 70-fold increased risk of pancreatic cancer, and chronic pancreatitis, 5 to 15-fold increased risk. Lynch syndrome, ataxia telangiectasia, post-Chagas syndrome, familial breast ovarian cancer syndrome, familial atypical multiple mole melanoma, familial adenomatous polyposis, risk factor of ampullary and duodenal carcinoma, and diabetes. Diabetic patient, all these are risk factors for pancreatic cancer. And pathology of pancreatic tumors, 85% it is ductal adenocarcinoma. 85% it is ductal adenocarcinoma. Intense desmoplastic reaction, extensive fibrosis, and difficult to differentiate from the pancreatitis. Spread may be locally, nerve sheath, blood vessels, and lymphatic, liver, and peritoneal spread. Cystic tumors, serous and mucinous. Serous, benign, old female, small and multiple, while mucinous, this is important because it is mostly malignant, potential for malignant transformation. It is either mucinous cyst neoplasm or intraductal papillary mucinous neoplasm. Adenomas of ampulla of water, pre-malignant lesion, may harbor invasive adenocarcinoma. It is ampullary adenocarcinoma and ampullary neuroendocrine tumors. And the clinical features of carcinoma of the pancreas: painless jaundice, pruritus, dark urine, pale stool because of jaundice, steatorrhea, vague symptoms like loss of weight and poor appetite, and recent onset diabetes mellitus over 50 with non-specific symptoms and attacks of pancreatitis. Body and tail of pancreatic tumor usually present late as a big tumor with backache. Tumors of the body and tail of the pancreas, presentation is usually delayed only when the tumors attain large size, and sometimes with backache, mostly with backache. Examination, jaundice, loss of weight, palpable liver and gallbladder, Courvoisier sign, signs of advanced disease, ascites, supraclavicular lymph node, and pelvic metastasis, extra. And investigations of carcinoma of the pancreas, pancreatic tumor, blood test, abnormal liver function test, anemia, tumor marker, CA19-9, ultrasound dilated CBD, pancreatic mass, liver metastasis, peritoneal mass, contrast, enhanced CT scan, and site of the tumor. In contrast, enhanced CT scan, we determine the site of the tumor, relation to the arteries and the veins, and duodenum, stomach, bowel, peritoneal lymph nodes, that's to say, nearby organs to the pancreas. MRI, ERCP, mainly therapeutic, stenting, sometimes when there is obstructive jaundice and stenosis of the ampulla of water pancreatic duct, we may require a stent. Endoluminal ultrasound, tissue to confirm the diagnosis, chronic pancreatitis and mucinous tumors. So it assists in taking biopsy material and diagnostic laparoscopy. Regarding the management of the carcinoma of the pancreas, 85% are resectable at time of diagnosis. That's to say, at time of a presentation, 85% of the tumor are resectable. So we use palliative treatment, whether medical or surgical, and in surgical treatment, sometimes we use triple bypass. That's to say, bypass the tumor. We do cholangio, hepatico-jejunostomy with jejunostomy in order to bypass the tumor, or operable surgical resection, head of the, either in the head or body and tail. If in the head of the pancreas and periambulary tumor, pancreatico-duodenectomy. If the tumor in the head of the pancreas, we use the operation, Whipple's operation, pancreatico-duodenectomy, resection of gastric interim, duodenum, head of the pancreas, CBD, and the gallbladder, or pylorus preserving pancreatico-duodenectomy. If it is in the body and the tail, we use distal pancreatectomy and splenectomy. In total pancreatectomy, a multifocal tumor, example, main duct tumor, or in the body and the tail of the gland, are too inflamed or too friable to achieve a safe anastomosis with the bowel, so we use total pancreatectomy. Palliation of pancreatic cancer, relief, jaundice, and treat biliary sepsis, surgical biliary bypass, stent placement at ERCP, or percutaneous transhepaticocholangiography, approved gastric emptying, and surgical gastroenterostomy and duodenal stent. Pain relief, stepwise escalation of analgesia, celiac block access, or transthoracic splanchnicectomy. Symptom relief and the quality of life, encourage normal activities, enzyme replacement for steatoria, and treatment of diabetes and consider chemotherapy. Then at the end of this lecture, 2 lectures about pancreatic disease, starting with the anatomy, physiology, injuries, congenital abnormalities of the pancreas, and inflammatory disease regarding pancreatitis, acute pancreatitis and its complication, causes and scores important like Ranson's score and Glasgow score, and management of acute pancreatitis. After that, chronic pancreatitis and definition and complication of chronic pancreatitis, whether local or systemic complications, and after that, carcinoma of the pancreas, which is bad tumor, and usually in 85% of cases it's resectable. It's either in the head of the gland, then we use Whipple operation, or in the body and the tail, we use distal pancreatectomy and splenectomy, and sometimes we use total pancreatectomy. Next lecture, we start with rectal surgery. 2 lectures about surgery of the rectum and 2 lectures about the surgery of anal canal. Thank you very much.